Okay, I am Dr. Nermeen Abu Saud, clinical pharmacy consultant from Prince Sultan Cardiac Center in Saudi Arabia. Actually, by chance, I presented this lecture 1 week ago in our clinical pharmacy club meeting in Saudi Arabia, so I have it by chance. Now I want to give a brief introduction about the historical development of clinical pharmacy worldwide. All of us know that the clinical pharmacy developed over the last 150 years from manufacturing, compounding, distribution to more clinical role, and finally to pharmaceutical care. And that was done through many steps until we get the last definition of the clinical pharmacy, which is the direct responsible profession of medication-related care for the purpose of achieving outcomes, which is a cure of a disease, elimination of symptomatology, arresting of a disease, and prevention of symptomatology. And this is a brief comparison between the pharmaceutical care and dispensing pharmacy. If you see, you will find that we change it from product-oriented to people-oriented or patient-oriented, and everything in the pharmaceutical care focus on the patient, serve patient business, not product, bring the practitioner to the patient, decision is made for the patient, and everything is for the patient. Now, this was worldwide. I'll go back to the Middle East, and I want to share my experience with you during the last 18 years from 1997 until 2015. I worked in many different hospitals in the Middle East in 2 different countries, in Egypt and Saudi Arabia. In 1997, I participated in the establishment of the first unit of clinical pharmacy in Egypt in the National Cancer Institute. Then I went to King Saud University. I was a lecturer of clinical pharmacy, and I participated in the establishment of the service in the hospital, King Khalid University Hospital in Riyadh. Then I took my students. I was a clinical preceptor, and I was teaching applied therapeutics in the hospitals, in the security forces hospital. Until this time, from 2001 to 2005, there is no clinical pharmacy services in these places. Then I returned back to Egypt to take my PhD in clinical pharmacy from also oncology. Then I went to Hamad Al-Mana General Hospital. It's a private hospital in Saudi Arabia. Then I went to another area in Saudi Arabia, which is Al-Qasim region. I established the clinical pharmacy services in 3 different hospitals, in King Fahd Specialist Hospital, and in the MCH Pediatric Hospital, and in the Cardiology Center, Prince Sultan Cardiac Center. So during all of this period, about 7 hospitals, I practiced clinical pharmacy in these different subspecialties. I came to my question, which is whether the subspecialty will affect our outcomes as a clinical pharmacist. It may affect the clinical and economic outcome. And how can I assess this? During all of my journey, I always believe in documentation, and I always document all my interventions, at least for the first year of my joining to any place. I keep documenting every intervention, every recommendation I give to the physician, because I know that we are in the beginning. We are the first generation of the clinical pharmacists in the Middle East. So we don't have in any hospital, we don't have a specific job description. Nobody knows what we are doing exactly. So I have to document what I'm doing, even for my directors. So over a period of maybe from 2005 to 2015, 10 years, I documenting all what I'm doing in all the subspecialties. So I had a huge data from many subspecialties. So I find that I can compare between the subspecialties by comparing the incidence of medication errors or recommendations that I give during these 10 years. So this is the aim of my study, is to compare the incidence of medication errors or drug-related problems between the 4 different hospitals in the Middle East from different subspecialties: cardiology, oncology, and internal medicine department in a tertiary hospital and pediatric hospital. Of course, the clinical pharmacy intervention outcomes were studied in many studies Each study focused on a specific subspecialty, but there is no study comparing between the outcomes in different subspecialties. This is the first study to compare. If you see, you will find that studies conducted in cardiology, hypertension, cholesterol management, anticoagulation, congestive heart failure, type 2 diabetes, chronic kidney disease, depression, acute care hospital, non-steroidal induced related problems, pediatric hospital, pediatric ICU, cancer therapy. So the objective of my study is to detect the incidence of drug-related problems in 4 different hospitals with different subspecialties in 2 different countries, Egypt and Saudi Arabia in the Middle East. The methods, the number of files, I took randomly 100 medical files from the patient that I saw. Selected and retrospectively I assessed all the drugs, doses, interactions, adverse drug reactions, contraindication, everything by using the drug therapy assessment worksheet, which is a sheet designed by the American Society of Hospital Pharmacists. It's about 25 questions that the clinical pharmacists use it as a systematic approach to detect the drug-related problems. The first question related to correlation between the drug and therapy. The second one related to the doses, underdose, overdose, dose adjustment based on the kidney function, the hepatic function, the absolute neutrophilic count in oncology, and so on. Elderly, some doses in elderly. Then the administration, the route of administration, oral, IV, bush, continuous infusion, IV bolus, with food, without food, duration of therapy, everything related to medication. It is specified in we should answer it. Drug-drug interaction, adverse drug reaction, monitoring parameters. If you have a drug, should be monitored. You have to monitor the kidney function, the potassium, whatever. So the monitoring parameter, whether it's daily or after 3 weeks, after 3 months, after 6 months, based on the medication. And of course, if there is a drug, we need to check the serum level, phenytoin, aminoglycosides, anti-epileptics, whatever, anti-cancer. Everything is in the sheet, and the clinical pharmacist should follow the questions to detect the drug-related problems. I took this sheet, and I used to use it during all the period. Then, of course, the outcome of the problem, it can be classified either medication error will decrease the efficacy of treatment, which is inappropriate drug selection, subtherapeutic dose, decreased length, drug-drug interaction, or increase the morbidity and mortality, or increase the cost. If you have a drug, you give it with overdose or therapeutic duplication of a drug. I converted this overdose to money, because this overdose, I was working in the beginning in oncology, and chemotherapy is very expensive. So I took this overdose, I converted to money, and I calculated during my PhD, I saved in 1 year about 2 million Egyptian pounds per year from the errors that occurring because of inappropriate drug selection, 2 antibiotics at the same time without a medical indication. So I converted each error to money, and I saved 2 million Egyptian pounds per year in my study. And of course, this was the system in each hospital. Then this is briefly, I cannot, of course, go through all the errors. The lecture already said before. These are certain types of errors in, I'll start with this cancer center. Some medication should be added as a pre-medication or prophylaxis in chemotherapy. It is not added. There are drugs should be replaced. It's mainly in chemotherapy related to anti-emetics. Based in the emetic potential of the chemotherapy, we have to either select ondansetron or metoclopramide. There is misuse of anti-emetics. Many medications should be adjusted based on the kidney functions or liver functions. Errors in the doses, because in chemotherapy, actually we have to calculate the dose based on the body surface area. Sometimes the patient came for the sixth cycle and he started the first cycle one year ago, and they take the body surface area 1 year ago, and the patient already lost weight during this period. So the patient will take overdose. If you have to readjust the dose before each cycle. Some of the errors I detected. Underdoses, some due to calculation error, increase the frequency of administration, wrong frequency, decrease the frequency, increased length of treatment, decreased length of treatment, drug-drug interaction through absorption, through metabolism, through excretion, enhancement, of course, the drug-drug interaction may be pharmacokinetic or pharmacodynamics. So this enhancement of drug toxicity through pharmacodynamic interaction and other mechanisms, this the results of oncology center. This is the result of internal medicine department in King Fahd Specialist Hospital, therapeutic duplication, inappropriate drug selection, underdoses, overdoses, decrease the frequency of administration, decrease the frequency also, increase the frequency, lack of adjustment based on the kidney function, based on the creatinine clearance. This is lack of adjustment based on the liver functions, maybe the AST and ALT elevated without dose reduction. Drug-drug interaction, this is a common drug interaction between calcium carbonate, which is given as a chelating agent for end-stage renal disease. Because of hyperphosphatemia, it's interact with all of these medications. So I found that sevelamer can also used, but it's not interact. So I give recommendation through the Pharmacy and Therapeutics Committee to change sevelamer, calcium carbonate to sevelamer. Clarithromycin also interact with all of these, as azithromycin can be used. Warfarin, metronidazole based on phenytoin interact with all of these. These are interaction. This is the pediatric hospital, the result therapeutic duplication also. The most common problem is they are giving 5 antiepileptics together, which is a very common with the initial dose without monitoring the serum level. It's a common problem. The two areas that are very common is antiepileptics and antibiotics in the pediatric hospital. There are many problems, also many therapeutic duplication in antibiotics because they are starting empirically. They don't know even where is the site of infection, so they are giving the available antibiotics in the hospital without guidelines, without rationale, without, I don't know. Anyway, underdoses, inappropriate length of therapy, all of this, the antibiotic for 2 days and shift, antibiotic for 1 day, and so on, without cultures, without drug-drug interaction, all of this. And this is the Prince Sultan Cardiac Center. Also, drug should be replaced by another based on the patient condition. Drug should be added, should be removed. Overdoses, underdoses due to overdose due to lack of adjustment based on the kidney, increased length, and so on. Of course, drug-drug interaction, so many medication errors in the 4 areas. So my results and discussion, this is the average rate of drug-related problems per file in each hospital. If you see, you will find that oncology and internal medicine department recorded the highest rate. And there are many factors because of that. One of the factors that is very common that the elderly people associated with many medication errors than the young. And oncology and internal medicine, almost all of them were higher. The age is more than 70. The other problem is when the patient is more than 70, the patient has many other comorbidities. This patient with oncology has also hypertension, diabetes, may has epilepsy, rheumatoid disease, and so on. So when you give the patient many medications, you complicate the issue, more interactions, more contraindications, and it's expected that oncology and internal medicine are subspecialties with higher incidence of medication errors than pediatric and cardiology. The percentages of different types of drug-related problems in cancer patient, if you see that we have about 17% of the errors, we need to add certain medications, and we have a problem in our hospitals that some medications cannot be given because it's not available in the formulary, and we have a problem in formulary management in our in Egypt or in Saudi Arabia. I don't know how they are formulating the formulary. It should not be done based on deals with certain companies, or it should be done based on our problems, our need, what the patient needs. It's not a business. It's not a business. So many of the drugs should be added, and I already raised the recommendation to the Pharmacy and Therapeutics Committee to add dexamethasone, amifostine, loperamide. About 15% are due to, they are unable to adjust the doses because the nurses, even the physicians, don't know that certain medications need dose adjustment based on the creatinine clearance. So I recommend to for our recommend to put stickers. Stickers when dispensing the medication that please monitor the kidney function, please monitor the liver function, and I already activated this in many hospitals that stickers should be attached to the drug before dispensing to remind the staff that we have to adjust the doses. These are the most common problems. We have to look in the formulary management policy. We have to put stickers. We can modify the electronic prescribing system and let the system help us in this. This is the result from the internal medicine department. About 52% of the errors due to drug-drug interactions, many of them can be prevented by searching among alternatives that will not cause this interaction, like sevelamer, azithromycin, and so on. This is the results from the children's hospital. If you see in the children's hospital also, all the drugs in the children should be adjusted based on the body weight, but actually this is not happened. So many errors due to not adjustment based on the body weight. Some drug-drug interaction. There is a very common problem in the children's hospital that in case of, if they want to make a gut sterilization, they should give neomycin. But because neomycin is not available in the hospital, they use gentamicin IV orally, which is a problem. That if a drug is designed to be given IV, you should not give it orally. And this is occurred many times in our practice. Even in the internal medicine, there is no phosphate orally. They are giving the IV phosphate orally. I don't know if, from my pharmaceutical point of view, I don't know how the physicians made this, but if the drug is designed to be given orally or IV, you should not give it in another route of administration. You are putting the patient under risk of something you don't know. If it can be, the company will tell you either oral or IV, and there are many drugs. It's for eye and ear together and kida. If can be, they will tell you. Otherwise, it's a problem. It should not be. This is the cardiac center, and also in the cardiac center, drug-drug interaction. I give many recommendations to replace many of our medications to another medications to reduce the incidence of medication error. The factors affecting the rate of medication errors, as I mentioned before, advanced age and comorbidities. If the patient with many comorbidities, the incidence of medication errors will increase. The patients with many medications and complexity of the disease, of course, cancer, and of course, the level of the prescriber. The consultant make less errors than the resident. We can make electronic modification on the system. We can make a training program to the pharmacy staff. We have to change the policy of recruitment of medications. And I already I participated in the pharmacy improvement project in one of the hospitals, which is the children's hospital. It's required by the quality that we have to make improvement project for the pharmacy department. And I tested some of these solutions that we can make educational program to the staff about the detected error in the area. I already made a series of the lectures to our staff in the MCH about the appropriate use of medication, many lectures. The other solution is to open an IV admixture unit to reduce the incidence of medication errors in the administration stage, because many medication errors occurred in the administration stage. So I established this unit, and we opened it, initiating a drug information center to help the prescriber about the appropriate use of medication. And I set the system, and I designed the drug information request form. And of course, this is the auxiliary labels that should be attached, and I succeeded to decrease the incidence of medication errors in the prescribing stage from 48% to 10%, which is the benchmark, and from 60% in the administration to 0% through the IV admixture unit, and from 55% to 15% during the monitoring stage of medications. And this is my last slide, and thank you.
Because it was very fast. But anyway, it was nice here. And unfortunately, I don't have a Oh, sorry, you have a question.
No problem.
You have a,
First, I appreciate your efforts. I can see the frustration that you have when you have all of these errors that you can see. But I think this is the best way to do to just document what's happening here. But the second step is to turn it into numbers. That what you get, you have to turn it into numbers and money, and not even include the cost of the drugs also, but also
Variable.
the variable.
Length of stay, everything, length of stay, and nursing time, everything.
This is a new concept now in the US, for example. Believe me, all of these things are in the US. All of it. Different levels. And this is a big issue. And that's why the farmers are setting these new documents for farmers, for education, for medication errors and safety. This is a big issue, I think. So I applaud you for that. You might be, you are a good farmers director. You can confirm these things. But the first step is to document it. But the second step is to tell the story.
Yes.
So I think the story here.
La la la, I told every day. Don't be crowding at the every day. Every day. Every day they would. Yes.
Guys who are responsible for that. And you started by making adjustments in the service. Yes, drug is important. TDM is crucial. You have to have all of this with CE and education. This is the way to work. And sometime, hopefully in the future, the big administrator will understand what you're talking about. And then when you prove to them that you're going to save money, this is when they're going to do.
Inshallah. Thank you. Okay,
Amen.
doctor. Okay. Thank you.
Amen. I'm sorry. You have to leave. I'm sorry. You have to leave in 5.